Hello and welcome to Under Pressure, the podcast where we explore how data, technology, and clinical decision making come together in trauma and acute care. I'm Dr. Jonathan Sackier, and I'm proud to be your host. Before introducing today's guest, it's important to specify that this podcast has been supported by Myo1, a Canadian medical device manufacturer. So please refer to the show notes for further information. And you can be in touch with us at underpressure@nextsense.com. That's underpressure at nxtscns.com. We'll stick that address in the show notes. And if you want to write, we'll endeavor to be responsive. Now, today's episode, this touches on one of the most debated topics in modern trauma care, the role of peripheral nerve blocks in patients at risk for acute compartment syndrome. Joining me, fresh from the operating room, is Dr. Jeff Gadsden, Professor of Anesthesiology, Chief of the Division of Orthopedic, Plastic and Regional Anesthesiology, it's easy for me to say, at Duke University Medical Center, one of the world's foremost experts on regional anesthesia and acute pain management at a top institution. Jeff has published extensively on safety, block techniques, monitoring, and more, and brings decades of real-world clinical insight to this topic. Beyond his clinical work, Dr. Gadsden's also a dedicated educator, course director, and international lecturer, someone who's helped shape how the next generation thinks about nerve blocks, multimodal pain management, and evolving tools like pressure monitoring. So, without further ado, Professor Jeff Gadsden, welcome to the Under Pressure podcast, and thanks for taking time out of the operating room.
Well, thank you so much, Jonathan, for having me. It's great to be here.
Fantastic. So, Jeff, you've practiced and taught anesthesia around the world, from Canada to Australia, and now you're in the Carolinas. Looking back, what sparked your interest in regional anesthesia, and what's kept you in the space? It's always nice to get a sort of to set the scene, if you will, why people do what they do.
Yeah, it's interesting. It's interesting how your early, experiences in your profession sort of change your trajectory. I was a medical student when I did an elective and saw someone doing a nerve block, and I just thought, this is the most elegant way to get someone through an operation. And they're awake and their arm is numb and they left smiling. And I thought, wow, general anesthesia is so 1840s. It's old tech, and we can do this with a more elegant solution. So that really sparked my interest. And then it's just I tell my trainees, I get up in the morning still. I've been doing this for 20 odd years, and I still feel excited about coming to work because I get to be like a wizard. I get to do magical things to people and get them through a really tough spot in their medical trajectory, and keep them feeling safe and comfortable and better.
Well, as a surgeon who's done a lot of procedures under regional blocks and worked with a couple of wonderful anesthetists, Mike Peck, if you're listening in, bless you and thank you. It really is fantastic from a surgeon's perspective, because you can chat with the patient if they're not sedated and kind of tell them how things are going on, and it's very reassuring, and they're completely pain free, which is it's marvelous. So let's get into the nerve block acute compartment syndrome controversy. There's this long-standing concern, because pain is one of the P's by which you diagnose this condition. And one of my orthopedic buddies told me, well, the various P's, pain, pulselessness, paresthesia, pallor, blah, blah, blah. That's now pain, 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 and pain. Well, as someone who's had a broken bone and has had a junior doctor coming to me and saying, how is the pain now? Well, it really hurts, right? It's
Right.
very difficult to draw a linear analog pain scale when you're in pain. So if you do a nerve block, you block the pain. Do you mask acute compartment syndrome? Why do you think this issue has persisted so strongly? It's way back to when I went to medical school back in the dark ages. And how do you approach this question clinically and get people to think differently about it?
Yeah, it's a great point. And the reason it's persisted is because the potential missing an acute compartment syndrome is catastrophic. So people lose limbs, and it's potentially fatal if untreated. So we never want that to happen. And the dogma was, as you pointed out, these P's, especially the pain or pain on passive stretch, is meant to be the cornerstone of diagnosis. But the truth, the sneaky truth of the whole matter is that the sensitivity of pain and the specificity of pain is not high for diagnosing a compartment syndrome. So we have to sort of unlink those two things. And what we've discovered is that when you provide a nerve block for someone who has a fracture that's at risk, a mid-shaft tibial fracture is sort of the classic case.
Right.
If you do a peripheral nerve block for that patient, you will take away the somatic pain, the pain that's bothering them from the periosteum and everything else, and they'll feel better. What is very, very hard to block is ischemic pain. And so with the nerve block. And so once a situation develops where an acute compartment syndrome is evolving, that patient will now begin to say, hey, I was feeling good 2 hours ago, but now I'm not. And that is, in fact, a way to facilitate the diagnosis, we think, because you have a patient who's doing well with a nerve block, and then suddenly there's been a change in their clinical presentation. And those patients get to then call their nurse, who calls the orthopedic intern, and then things sort of get ducks get lined up, and people start looking at compartment pressures and that sort of thing. In contrast, as you pointed out, the broken bones hurt, and so I'll gently challenge my orthopedic surgeon colleagues sometimes and say, well, what are you going to do for this patient if a block is off the table? And often the response is, well, we can give some morphine or do a PCA opioid. And I think, well, that actually will block ischemic pain, and patients can then titrate opioid until a point where they are incoherent and they have an evolving compartment syndrome, and nobody knows about this. So maybe the block is the most thoughtful way and elegant way, as I said, to help facilitate the diagnosis. The tough part is it is orthopedic dogma, and they get it drilled into them as trainees for good reason.
Yeah.
That we can't miss this. And so there are ways that we have we've worked with our orthopedic surgeons, and our orthopedic surgeons are great at Duke, and getting towards a team-based approach to doing the right thing for the patient and making sure we never miss a bad outcome.
Yeah, you explained it very, very eloquently, and I mean, my experience has been that when you're trying to teach residents a new way of looking at something, if it has been repeated multiple times, um, well, then it doesn't. It's very difficult to erode it. But coming at it as you have done, round the other way, well, what are you planning on doing? I'm going to make my patient completely doolally with opioids.
Right.
Oops, that's
Yeah.
so crazy.
Right.
So, I'm sorry. Go ahead. You wanted to?
Yeah, I was going to say, and then if you look at someone will then raise their hand and say, well, where's the evidence for all this? And there's no randomized controlled trial that I can point to. It'd be very hard to do that, right, ethically in the patient. But we have an increasing amount of case series literature and case report literature showing exactly that you can do a block in someone, makes them comfortable, but then when those cases occur where you start to get ischemic pain from acute compartment syndrome, it breaks through. That happens, and in fact, there's no case report in the literature of a block masking a compartment syndrome.
Right.
I should say a peripheral nerve block. An epidural is a bit of a different animal, and so we tend to avoid those in these
Right.
situations. And
Yeah.
but in contrast, there are several case reports of patients having an opioid PCA that delayed the diagnosis, and then bad things happened. So,
Yeah.
So I think it's hard to point to great quality evidence, but I don't know that you have to in these situations.
Yeah. Well, I'm whenever anyone mentions evidence, I always think of two things. Number one, older surgeons will say, well, all this evidence is fine, but I have my experience to go on, which is one. The other is that classic article that I think was in the British Medical Journal, the absence of a randomized, prospective randomized double-blind controlled clinical trial um, that demonstrate that parachutes actually do prevent gravity-induced injury. It's classic. So, in some of your writings and lectures, Jeff, you said it's not just about the block, and you've just hinted at this. It's about knowing when and how to use it safely. Can you take us through how you think about the process, especially in cases where you've got compartment syndrome potentially to contend with?
Right. So to me, it's all about great communication, and great communication is going to, as is often the case, solve 90% of our problems. So getting on board with my orthopedic colleagues at the outset and saying, what are you concerned about? What is the risk profile for this fracture? What time period do you think he or she is at risk for? And then let's talk about a block and what that would look like. And then so another facet of this is having hands on the patient to ask the patient how they're feeling, and examine the patient, feel those compartments, to the extent that a clinical diagnosis is accurate. But an argument I make sometimes is, look, if we place a catheter or do a nerve block, and now that patient's being followed by our pain team twice a day, that's two more sets of physicians' eyes and hands that are on that patient and being able to intervene quickly if we think that something's not happening right. So that's sort of the basis of the conversation. And then the next part, once we've decided yes, a block is appropriate for this patient, is sort of figuring out what the right block is, what the right concentration of local anesthetic is, because um, that sometimes is a mitigating factor. If we say, well, look, we'll do a low concentration block that will just take out the sensory fibers, and the patient can still move their foot, that gives both sets of teams a little more confidence that we're not completely ablating any input from that fracture site.
Okay. Um, there's a growing view that continuous pressure monitoring can help mitigate the risk of masking acute compartment syndrome. I always think about doing sequential checks on the patient, possibly different people, and this is all, of course, very subjective. From your perspective, does that shift the calculus on whether or not to block?
Oh, absolutely. I mean, the truth of the matter is we don't think blocks mask it, so that you should be able to rely on that clinical exam. But that's as we've said, that's a hard argument to make sometimes. And so if I get far enough down the conversation, my sort of trump card, as it were, is, well, look, if you're that concerned about this patient, you should be doing objective monitoring, not relying on a clinical diagnosis from an intern that may or may not be accurate. So, and if we have that clinical monitoring with objective numbers in place, then it's irrelevant to, if the patient can or can't feel things. We have data to show, yes, the pressure is X. So I think that absolutely changes the calculus.
So, but you've already mentioned this. It's key to make the point. It's really important to make the point. This does not replace clinical acumen, seeing the patient, talking to the patient, looking for other signs. It's an analogy I've used before, Jeff. So anyone listening in multiple times, I'm sorry if they're hearing this again. I fly aeroplanes for navigation, and the aeroplanes I fly have multiple fuel gauges. I don't want a spot view of how much fuel there is. I want to see what's happening to the trend Am I, if the fuel gauge is showing I'm 3/4 full, and 2 hours ago it showed I was 3/4 full, the fuel gauge is broken, right?
Yeah,
Because
exactly. Right. That's a great analogy. I'm going to use that.
okay, please do. So you've trained fellows and residents for years. How do you guide them through making the right call when it comes to blocks and possible compartment syndrome? Do you see younger clinicians more or less willing to adopt new monitoring tools, especially with the hours of work issue? I mean, I certainly trained in the era where one works more hours than there were in a day. So, yeah, how do you manage that?
Yeah, I do think that trainees these days are much more likely to want to have that objective data and to use some sort of a, a monitoring tool that we can monitor intermittently or continuously throughout the course of the patient's stay. Um, it's just it's sort of like you were alluding to earlier. I mean, the old dogs like me or you, we trained in a time where we didn't have these things, and nerve blocks weren't really all that common, and so we have a set of principles in our head that we've had to sort of adjust to. But the young kids coming up with all the, they're used to video games and used to having instant feedback on a lot of things. I think it's a much easier argument to make with a orthopedic surgeon who's just fresh out of school and saying, look, here's our plan. We're going to do this. It's going to take away sensation, but you can use this to mitigate that or protect against this bad outcome. That they see that instantly.
Right, right. So, what about outside of compartment syndrome? Do you see a broader role for continuous pressure data, perhaps in making other interventions safer, guiding pain management strategies, other scenarios? For instance, when I first heard of this technology, I thought about abdominal compartment syndrome, something that one deals with, perforated diverticulitis or abdominal trauma, and the decision to take someone back to the operating room has implications. If you have to nurse someone through a laparostomy, it's you're committing yourself and the poor patient to many, many weeks of this. So yes, your thoughts.
Yeah, I think that's a great example. I mean, any time that you can, uh, be monitoring that pressure and clarify that decision making point where you're saying, well, let's just go and do an operation because that might be the right thing to do, but then again it might not be. So that objective monitoring is, I'm a big fan of objective monitoring, and data is how we should be making these decisions as opposed to um, you know clinical suspicion and that sort of thing. So I think that's a great case example, the abdominal one.
And to continue the aviation theme in your profession, it always struck me that anesthesia, the flight should be like fighting a war. They say that uh, brief periods of excitement and long periods of boredom. That's what you want in anesthesia. You want what you want, but inducing anesthesia, maintaining anesthesia, waking the patient up, and framing all that. You're doing all that with data and a lot of data, right, to make your decisions.
Exactly. And a good anesthesiologist makes it look boring. So that there's a
Yes.
lot of, it's like a duck, there's a lot of stuff happening underneath the surface, all the paddling. But, we want to project that calm, controlled image. But yeah, there's a lot happening there that a lot of people don't appreciate, um, in terms of the interpreting all that objective data.
Yeah, very much so. So you recently co-authored a piece on lower extremity blocks in patients at risk for ACS in the orthopedic clinics of North America. Can you walk us through that paper, what you hope to clarify for your colleagues in both anesthesia and surgery?
Yeah, that was a nice little collaborative effort, amongst some other interested parties. My friend Jerry Jones from Tennessee has spent a lot of his career caring for trauma patients, and he and I share this interest. So we were co-authoring that together. I think there's a lot of mythology around this, and a lot of, like we said, misconceptions about the physiology of ischemic tissue and ischemic nerves. And so that was part of our mission, was to clarify, hey, this is how acute compartment syndrome manifests as pain. It's not somatic pain. It's not the pain that you get when you cut yourself with a knife. It is deep, visceral um, pain that's mediated by different fibers than the somatic pain. And so, if we're turning off just the somatic fibers with a nerve block, that permits us to pay attention, and for the patient to pay attention to that evolving visceral type, deep pain from the ischemia. And so that was sort of the first point we wanted to make. And then the next point was some strategies around how to navigate this, because in the real world, there's going to be some reluctance. And part of my part of my mission has been to break down some of these misconceptions, but you got to do it with baby steps. And so a strategy or a tactic we've used is say, well, look, we'll place a catheter at time 0 in the operating room. I know you want to have the patient have full sensation. Let's do that for 24 hours, and then we'll turn the catheter on. And then once they're out of that risk period, and we've done, it's not the best solution in terms of making the patient as comfortable as possible, but but it allows the patient to benefit somewhat from that block. Another tactic we've used successfully is again lowering the concentration of that local anesthetic, and so that will just provoke a sensory block, hopefully, and allow the motor fibers to function. So having and sometimes the sensory fibers as well. So you're just getting um, the pain fibers, the A delta and the C fibers. So that's ideal, because then you can have the patient moving their foot. They can yeah, I feel you touching my foot, but I don't have any pain. And then at some point, if they do, then that's the time to go and really pay attention to the compartments. So that was kind of the thrust of that article.
Interesting. In a similar vein, you've recently contributed to a work on awake spine surgery. This was certainly news to me, showing reduced length of stay and opioid use, which didn't come as a surprise to me. What have you taken from that experience, and is this approach catching on? Where's it headed?
I'm just going to wait for 1 second because there's a fire alarm, and the guy's making an announcement here. So I want to wait.
Yeah, I can hear.
Yeah. I guess that was it. Okay. Yeah, this has been really interesting too. And this came to us from a surgeon. He had a patient in clinic who said, I'm willing to undergo spine surgery to fix the pain that I have in my back and my leg. However, I'm deathly scared of general anesthesia. Is there a way that I can be awake through this? And the surgeon said, I don't know. Let me ask my anesthesia colleagues. And so and it's not a new thing. I mean, people have done spinal anesthetics for spine surgery before, but we just we took that one experience, and it went fine, and then started to build on that and create a whole protocol. So now for these patients, we do a combination of a spinal anesthetic that gets them through their sort of 3 or 4 hour um, surgical procedure, and then also some erector spinae plane blocks on both sides bilaterally in the lumbar spine, so that when the spinal wears off, they feel great. And so one of the challenges with spine surgery is that a lot of these patients come in with a high pain burden, a lot of opioids preoperatively, and the recovery can be very, very challenging. In the recovery room, once they've woken up after a general anesthetic, they're often miserable and very, very challenging to get good pain control. So the combination of the spinal and the erector spinae plane blocks just really soften that landing. And so they're awake and they're chatting and they're eating in the recovery room, and then once their legs come back to life, they feel, hey, I feel pretty good. I can walk a few steps, and we've really flipped from making some of these multi-level lumbar spine procedures taking it from an overnight procedure to outpatient day surgery.
I'm thinking back to the advent of BIS monitoring in anesthesia, which and learning about how depth of anesthesia, dispelling the myth of people waking up in the middle of operations. I used to joke with my anesthetist, I don't necessarily want him paralyzed, but could you at least slow him down a bit, Mike? Which my wonderful friend and anesthetist would like stick his tongue out at me metaphorically. But I think about how that metric was used to control the depth of anesthesia to limit the post-operative bad vibes of having a general. And I'm actually thinking about the genesis of local. I believe it was Halstead who was the progenitor of local anesthesia, based on the work of Freud in injecting cocaine into himself, into his face, the infraorbital nerve, I think it was.
Yeah,
Um,
yeah, that's right. I William Halsted was a remarkable figure in
yeah,
medical history, and he did that self experiment at
yeah.
Roosevelt Hospital in New York City, where I trained and worked there for several years before moving to North Carolina. But yeah, if it weren't for he unfortunately became addicted to cocaine,
He did, yes,
as you
yeah.
might after a bunch of self injections. But
Well,
we can
that's
we can point to him in 1886 as the very first nerve block.
yeah, yeah. Taking one for the team, I guess.
Yeah.
Fascinating story. There's a great book about it called Genius on the Edge. It's a
Mm.
fabulous, fabulous study, which I think surgeons and anesthetists both would really enjoy. You've published extensively on liposomal bupivacaine in joint and fracture surgery. What Talk to us about the evolving pharmacology of long-acting blocks. What are the biggest misconceptions about using them safely?
Yeah, this is also a really interesting and dynamic part of regional anesthesia practice now. We understand that there's huge benefits to be conferred when you do a block for somebody. But if that block wears off after 12 hours or 15 hours, you've almost put them in a worse spot. They're waking up in the middle of the night and now they're screaming in pain. So anything we can do to extend that block is going to be great for a lot of patients. The cat We can do that with catheters sometimes and some other adjuvants, but there are limitations to that in terms of technical expertise and the infrastructure needed to manage catheters. So this liposomal bupivacaine, which is just a slow release version of bupivacaine, it releases over 3 or 4 days, has been very useful in a lot of different settings. One of the things we've had to learn the hard way is it doesn't behave like a regular local anesthetic in that it won't cross fascial barriers. So if I were to do an interscalene brachial plexus block for you right now, I could, with regular local anesthetics, bupivacaine, ropivacaine, I could be somewhat sloppy with that and put it a centimeter or two away from your plexus, and you would still get a decent effect. If you do that with liposomal products, we've realized is it totally fails. And so this mandates a degree of precision that I think a lot of us do anyway, but it's the I think where we've seen challenges is in the occasional regional anesthesiologist, someone who does blocks, here and there, and may not have the experience to make sure that the precision is really on point. And so that was a big aha moment for us, is because if you look at the literature on this, the first 8 years of literature is all over the place. Maybe it works, maybe it doesn't. And then we kind of all collectively realized, oh, we're using this in the wrong way. We can't just go squirt, squirt, squirt into a joint. We need to be very, very precise.
Okay. So that's one form of failure. Let's talk about failure. Blocks don't always go as planned. You've published and spoken a lot about what happens when blocks fail and how to manage those situations. What should clinicians know about risk, reversibility, and rescue strategies, the three R's?
Somehow I've found myself in this niche of block failure. I was asked to give a talk at a lecture, and then at a meeting, and another talk, another meeting, and then someone invited me to co-author a paper on block failure, and suddenly I realized, am I the block failure guy? Um, what
Be
are you
careful what you
what
wish
are you
for.
saying about my practice? Um, so so yeah, blocks are not for everyone. So one of the things we try to get across to our trainees is that you have to be fairly selective. Like, I'm a huge fan. I think what we do is, I feel like Harry Potter most days. Just, my needle, my wand comes in 22 gauge. That's the difference, and making magic happen. But there are cases where you have to be a bit thoughtful about unanticipated effects of having a block, and not everyone needs to have a numb arm or a leg for 2 or 3 days. That's number one. When you have when you go down the road of doing a block and it doesn't set up like you expect, we have a number of tactics and strategies to sort of address that. And doing the use of ultrasound has changed how we manage that. So we can now pick off nerves anywhere along the course of their anatomy in a way that we couldn't pre-ultrasound. You sort of had one shot to do it, and if it didn't work properly, you were kind of out of luck, because you never wanted to stick a needle into someone without them feeling it, for fear of stabbing the nerve with the needle. But now I can see the nerves with ultrasound, and so doing a rescue block partially down the arm or forearm has been much more easily achievable.
Right, right. But Haley, look, it's a great point that it isn't for everyone. Not every procedure is for every practitioner, and having the humility to say, yeah, no, this isn't for me. I don't want to be doing that. It's a bit of an offbeat question, but it's inspired by a comment I made earlier. I was flying aeroplanes long before I was practicing medicine, and so I've tended to use many of the thought processes in aviation, and it's impacted the way I practice surgery. When you're not thinking about nerve blocks being Harry Potter or Gandalf or a wizard or whatever, what keeps you grounded? Hobbies or experiences outside of medicine, have they helped shape your mindset inside the operating theatre, the operating room, and the research lab?
Yeah, it's I like getting outdoors. I love to run, and running is one of those things that my mind is just, it clears my mind, and I have my best ideas when I'm on a run. I've actually stopped. I frequently stop in the middle of a run, make some notes on my phone. Hey, I should do this, or I should try this, or what about that? And that's how I unwind. I've really during COVID, when we were not operating for 3 months, and we were just sort of making taking care of patients in the ICUs. um, I got into video editing, and initially it was just for like um, family vacation videos. But then our group decided, hey, we've got a lot of expertise. This could be a really cool thing to make some educational videos about regional anesthesia and some other medical topics. And so we started doing that, and it ended up being a real thing that we did as a group. And we collected enough of these little videos that we decided to make something called Blocktober, where we released a different educational video each day of the month for October, and sort of promoted it on social media. And that was in 2020, and then we've just kept that going every year. So we're 5 years out, and Blocktober has kind of grown and grown, and regional people around the world kind of look forward to it, and chime in, and there's a lot of interaction. So that's been kind of fun. That's another outlet.
That's very cool. Blocktober. It's like the moustache people have Movember.
Yeah.
What about a piece of advice that you always give to residents or fellows when they're just starting their journey into anesthesia or trauma care, and whether it's about blocks or anything else?
Um, I think the biggest a piece of advice. I have lots of advice. You can ask my trainees that they can't shut me up sometimes for giving them stories and bits and pieces. But I think one of the things that is most important that I try to get across to the trainees is put yourself in that patient's shoes. I want you to imagine that the person you're about to walk over there and introduce yourself to and start talking about sticking a needle in their body. I want you to pretend that's your mother or your sister, and um, and just pause and think about what you would want to say to your sister or your mother. And I think it's very easy in a busy trauma practice and a busy, you know, anesthesia practice. We're running all over the place all day long to sort of forget that there's a, you know, a living, breathing human on the end of that needle, and so and that sort of that pause, I think, sometimes helps us to influence the decision making a bit. And back to your point about not everyone needs a block and not everyone needs to have X, Y, or Z. So yeah, that's something I try to get across.
Yeah. Jeff, what have I failed to ask you that you would have wished that I would have asked you? If so, please chime in with it. And if I was thorough, can you provide like a pithy take home message, the one thing that you would hope the audience would have taken away from our conversation?
No, I think this has been a great discussion, and I think that as in terms of a take home message, I my message to anybody who looks after patients with acute compartment syndrome is it's a team sport, and you can provide enhanced care for these injured patients when you sit down and talk with your from an anesthesiologist point of view. If I sit down and talk with my surgeon about this and explain, understand their fears and concerns, and offer solutions to address those fears and concerns. So coming at it where I failed personally in the past is not communicating well and trying to do my own thing in a bubble, in a silo. So the I think the best is often the case. The best approach to patient care is as a team.
Well, I'm going to finish with an aviation analogy yet again. Have you ever been on an aeroplane that is coming into land and executes what we call a missed approach, where they're about to land and suddenly they ram on the jets and pull away?
Yeah, it was one of the scariest experiences of my life. I didn't know what was
It
happening.
happens every day and every time I'm on an aeroplane and the pilot doesn't say something like a few seconds after that, uh, this is Captain such and such. You'll have noticed that we didn't land and instead we climbed up again. It's not because we love flying that much. It's because there was insufficient clearance between the plane in front, the wind direction changed. This is nothing to worry about. We do this the whole time. We're just going to go on a little sightseeing flight around the airport and we'll be coming back in and we'll have you on the ground sooner or later. But they never do. So everyone is sitting there absolutely quaking with terror. And whenever I took people flying, I had a little article that I wrote telling them what was going to happen and saying, here are the periods that you can ask me questions. When I press a
Mm,
button, I'm going to show you the button. Please don't talk to me because I'm focused. And it takes away all the concerns, right? And when doctors fail to talk to their patients, they actually make the experience a lot worse. Just
yeah,
putting your hand on a patient's shoulder and saying, here's what's going to happen, here's what you're going to experience, and here's what we're going to do to try and make it as pleasurable for you as possible.
100%.
Yeah.
I was on a plane last week. We were starting our acceleration down the runway to take off, and then all of a sudden the brakes got slammed on. Now that's never happened to me. I've had the missed approaches as well, but stopping the takeoff, and everybody was wondering what's happening. And it wasn't until 15 minutes later. Now we're sort of back at the gate, and he says, "Well, we had a light that went on our dashboard, but we think it's all better now," which wasn't a horribly
That's not
reassuring thing to
reassuring.
say.
No, hell
We
no.
think it's all better now.
It's
Um,
better.
it all went. We took off again, and everything was fine. But yeah, I think your point is great. I think that that timely communication, explaining things is is necessary and appreciated.
Yeah, we have a thing: aviate, navigate, communicate, fly the
Mm,
airplane, go in the right direction, and then tell people what the hell you're up to.
that's
Professor
good.
Jeff Gadsden, total delight talking to you. I, for one, will be going to bed less dumb tonight because of your wisdom, and I love the way you described the differences between your, a well executed block and systemic opioids. Thank you so much for your time and everything you're doing for this science. Bless you.
Thanks so much for having me.
So, folks listening in, thanks for taking time out of your busy day so that you can deliver better care for your patients. We all want that because we're all going to be patients sooner or later. Please share this with your colleagues, listen in to other episodes. And if you want to ask questions or make suggestions for other topics you want to see us cover, please write to underpressure@nextsense.com. That's underpressure at nxtsens.com. We'll stick it in the show notes. Thanks also to My One for supporting this podcast. And all that remains for me to now say is I'm Dr. Jonathan Sackier. I'm very proud to be your host. Please, everyone, stay safe, stay well, stay curious. Bye for now.